organization. So I'm gonna start by introducing this lecture and then mentioning the indications, segmental anatomy, normal and variant vascular anatomy types of surgical resection, and future liver volume. In this lecture, I'm not going to talk about the liver transplantation. I'm talking about other types of surgical resection. So assessment prior to liver resection is a challenging mission because of the complexity of the disease and occult nature of the disease, the changing epidemiology, and rapidly evolving diagnostic and therapeutic approaches. It requires multidisciplinary approach involving diagnostic radiologists, surgeons, hepatologists, oncologists, interventional radiologists, pathologists. So to really talk about each case and evaluate it case by case basis. The liver resection is indicated for a variety of pathological processes, and the common malignant indications include hepatocellular carcinoma, cholangiocarcinoma metastasis. Those are the main indications for surgical resection. A radiologist should start, number one, by detection, proper characterization, localization, and the staging. As far as detection, multiple studies and meta-analysis indicated the comparable effectiveness of contrast-enhanced ultrasound, multidetector CT, MRI, with closely similar sensitivity and specificity. However, in our real practice and observations, we strongly recommend it to evaluate those by gadoxylate disodium enhanced MRI. The reason for that is you obtain the highest detection by gadoxylate disodium MRI, which is called in Egypt is called Primovest, of course. In America here we call it EOVest. That's for detection. And this is an example of how you can miss metastasis in the liver in a standard contrast enhanced MRI, which can be very well revealed on the 20 minutes hepatobiliary phase when the surrounding liver uptake the contrast, leaving these metastases without uptake. So these are multiple metastases again, which were not depicted in the standard contrast enhanced MRI, but they were easily seen in the hepatobiliary 20 minutes phase where it can help in better surgical planning. Another thing that you have improved the detection in MRI. In fatty liver, condition like fatty liver, hepatic steatosis, you have so much difficulty by ultrasound, and you also have so much difficulty by CT in detecting focal lesions because this, first of all, it causes a lot of artifacts on ultrasound, and on CT, the diffuse hepatic steatosis, frequently obscure the underlying pathology. So you may not be able to detect liver metastases. But in MRI, you have the opposite. MRI even improve the detection. So here you see in phase and out of phase, where the surrounding liver has severe hepatic steatosis. You can't even tell the liver here from the surrounding lung, but you see the metastasis standing out in the background of this liver. So you have also you have the gadoxylate disodium hepatobiliary phase. You have the added value of in phase, out of phase, like in cases of severe limitation by diffuse hepatic steatosis. In other modalities, MRI can help you better. And the other pulse sequences in MRI can also help increase the sensitivity and the specificity, such as diffusion weighted, and you can have restricted diffusion in this metastasis, and also T2 weighted images where metastases stand out. And not only that, but also you can assess for fibrosis, which is very important in assessing the condition of the residual liver volume, right? So you can do MR elastography for fibrosis. The second thing is proper characterization, and this is a case of a 65-year-old female with primary sclerosing cholangitis. In case of primary sclerosing cholangitis, you need to pay attention for, in the liver and, try to exclude any possibility of cholangiocarcinoma, for example. And here we see this enhancing observation in segment 4 of the liver, which become iso-intense in the venous phase. But you see also an anomalous vein supplying, and this become iso-intense on T2 MRI. So this is uh, aberrant right gastric vein, and leading it to this pseudo enhancement and pseudo lesion, which can lead to this misdiagnosis. So first, confirm that you're dealing with true lesion rather than a pseudo lesion. So that's the proper characterization. Another thing here, this is another example. So what is third inflow? And I'm mentioning this in particular because that has the tendency to be mistaken for other pathologies. Here you see this abnormal enhancement in segment 4, and you see aberrant right gastric vein supplying it. So basically it's called third inflow. Third inflow because liver has dual blood supply, which are mainly portal vein, providing 75% of the blood supply to the liver, and the hepatic artery supplying 25% of the blood supply to the liver. When you have a third source of blood supply, this is when it's called the third inflow. And the usual course of right gastric vein is to really drain in the portal vein, and then the portal vein will supply the rest of the liver, the entire liver symmetrically. But this is anomalous vein. So instead of draining into the portal vein, it goes directly to to the left liver, particularly segment 4. And even though it's in the left liver, it's called aberrant right gastric venous drainage, not to be mistaken for metastatic deposit or any other pathology. So this is third inflow. Those are, and this is the anomalous vein supplying it, and this is the enhancement or the pseudo lesion. And this is the schematic showing you what it happens in this uh, specific condition. And this is again the description of third inflow, which I have described to you. This is an example of aberrant left gastric vein. This is an example of pericholecystic vein, and this is pseudo lesion secondary to the caudate loop. And all of these share the uh, pitfall of perhaps being demonstrated as a pseudo lesion and can be mistaken for a true lesion, and you can see an anomalous vein or anomalous vessel supplying it, right? So this is third inflow. Proper characterization also, this is a case that has been presented to us with colon cancer, and this has been mistaken for metastatic, for hemangioma, just because it fills in. But metastatic deposit can also fill in. What's the difference between this and that? This is also in patient with colon cancer, and this one was interpreted as metastatic deposit. The fact is that this is not metastasis. This is not hemangioma. It's metastasis, and this is not metastasis. It's sclerosing hemangioma. I see why this was misinterpreted, because if we go back to the case, it doesn't demonstrate the routine typical imaging features of hemangioma. It rather have a continuous rim of enhancement, capsule retraction, and complete enhancement. So this fits hemangioma, but these other characteristics do not fit the characteristic of hemangioma. Those are continuous rim of enhancement with capsular retraction, right? But what's the difference? And what's the difference between this, which was again, this was misinterpreted as hemangioma, this was misinterpreted as metastasis. What's the difference between this and that? This is sclerosed hemangioma, and that's why you see the capsular retraction. Sclerosed hemangioma is hemangioma that has sclerosed and become fibrotic. That's why it tends to cause volume loss with capsular retraction, as we can see here, right? But the tip here for diagnosis is that this sclerosed hemangioma follow the blood pool enhancement. You see it here, it's very comparable to the phase. So in arterial phase, it follows the artery. In the venous phase, it follows the vein. In the dilated phase, it follows also the blood vessels. Metastatic deposit does not here demonstrate blood pool enhancement. So it fills in because of its abundant interstitial space. That happened with the fibrotic tumors, such as metastatic deposits. Okay, they accumulate contrast and they can lead to this enhancement in the delayed phase. Okay, so the key home lesson to take here is you can do biopsy if you're not sure. Don't say it's just metastasis, but you don't do that for everything. If it's metastasis, it's metastasis. But if you are not sure, like here or there, then you can do biopsy, right, for these lesions. But these are types of cases which were misinterpreted. This one was misinterpreted for meningioma, but it's metastasis. This one, it was misinterpreted for metastasis, but it's hemangioma. This one follows the blood pool. This one doesn't follow the blood pool. The third step is accurate staging. Uh, and this is, for example, the Barcelona clinic staging for HCC, which we go by. And you can see here about the tools for or routes of treatment. Here you can see liver resection, locoregional therapy. So resection is one of the the management options for this patient, and it will be based on the stage where you see it in the liver. And I'm not going to go over this in detail, but it's very important to apply the stitching system of each tumor. Like we have specifics for each of these. This is, for example, a very early stage HCC. And the treatment here, like what we see here, is just wedge resection, as we can see in this patient. Okay. And it can be also doing ablation, by the way, but that's what happened. This patient, again, wedge resection for this patient with early stage of hepatocellular carcinoma. And we're going to go over this in more detail, what wedge resection means and other types of resection means. So we mentioned the detection and the importance of detection, and then staging, and then detection, characterization, and then staging. And very important is to have then proper localization. The surgeons will really look for this as one of the most important information you provide to them. So you start by segmental anatomy. You master the segmental anatomy. This is not anatomy lecture, but I'm going to go over, some tips here. And then vascular anatomy and anatomical variants. So you tell them this is within segment 8, for example, and that's how that's vascular relationships, and those are the anatomical variants. And as we know, these are the liver is having 2 lobes and 8 segments, as we can tell here from this picture. We all know about it, so I don't want to be redundant. But from 1 to 4 segment, left hepatic lobe, and from 5 to 8 is the right liver lobe. These are some principles which we need to master and know about. So again, liver supplied by hepatic artery, but this is important for the beginners. So liver supplied by the portal vein, hepatic artery. As we see, we need to know about also biliary drainage, and also it's drained by the hepatic veins going to the IVC and the heart, right? So very important knowledge for us here is to know that there is significantly decreased risk for ischemia because of this dual supply, blood supply, what's called hepatic buffer. Because when portal vein increase flow increases, the hepatic artery decrease and vice versa. So if there is occlusion for one, there will be increase in blood supply by the second one. And this is the ultrastructure or histological microscopic unit, which is liver sinusoid. And you can see here the branches of hepatic artery, portal vein, bile ducts in the corner. And you see here the central vein centrally in this sinusoid, and then this central vein will drain to hepatic veins and then the IVC. Preoperative imaging evaluation provides vascular roadmap. That's what you need to tell the surgeons. This is my vascular roadmap, and these are the variants which we have in this patient. Variants are quite common in the liver. Recognizing the blood supply will significantly help in reducing the morbidity and increasing the safety margin in these patients by assessing the vascularity of the remnant liver for the likelihood of its regenerating to its original size post-operatively. The hepatic variants, as I said, the vascular variants are quite significant. So here, for example, the classic arterial anatomy is only 55% of patients. And the variant anatomy is about one third, not exceeding, for about 45%. So a little higher than one third of the patients. Overall, entire vascular variance is around one third of the patients will have vascular variance, right? So but that's a classic arterial anatomy, as we can tell. It's like originating from the celiac trunk, common hepatic artery, then after giving the gastroduodenal artery, you have the proper hepatic divides into right and left hepatic artery. But these are the variants, and we can see very many of them, and you need to recognize them. And as we stated, 45% of the arterial supply have variant anatomy. And the typical variant anatomy for those is like replaced or accessory right and left hepatic duct. So, for example, this is an accessory. I'm saying accessory left hepatic of the left gastric artery. I'm saying accessory because you have the left hepatic artery here, but it can be all replacing the left hepatic artery. So when it's replacing, it will be taken over the left loop supply, and so on. Same thing for the right hepatic artery. So left hepatic artery replaced or accessory typically from the left gastric, and right hepatic artery accessory or replaced can be from the superior mesenteric artery, you know. So we need to assess these because those are very important. I'll show you some examples of troubles that can happen. Like, for example, this is an accessory left hepatic artery. Again, you see, you say accessory because there is the, native hepatic artery, left hepatic artery is here. So this is accessory left hepatic artery. What happens if you don't mention this in your report? What will happen is they will actually fail to ligate this left hepatic artery. If you're doing left hepatectomy, you need to ligate the blood supply for the left lobe of the liver. But here, in such case, you will take out the left hepatic lobe and you will leave this one, and that will happen when you don't mention it. Then there can be this gush of blood from the accessory or replace the left hepatic artery. Those are several hepatic portal vein variants, anatomy and variants, and this is type 1, which is 65%, and it has a classic portal vein anatomy, portal vein, left portal vein, right portal vein, and the right can, be divided into anterior and posterior right portal vein. But you can have several other portal variants, like 35% of the portal supply will have variants. And those are some variants here. You need to depict this and you need to mention those to the surgeon. For example, same thing will happen if you don't mention them. So like, this is, for example, left portal vein from right anterior portal vein. It's originating from the right anterior. So this is a portal vein, and then it gives the right portal vein. Right gives the right anterior portal vein, and here is the left portal vein. So left portal vein here is originating from anterior sectoral branch of the right portal branch. And this is very similar, but you have here anterior sectoral branch, anterior portal vein, anterior right portal vein of the left portal vein. Okay, so imagine if you're not mentioning those as well, what will happen? Severe bleeding, because the surgeon would be just ready to cut through these when they do left or right hepatectomy. That's also trifurcation of the left portal vein, where you can see the left portal and right anterior portal and right posterior portal, all originating from the same portal, from the main portal vein. So that's trifurcation of the portal vein. The hepatic venous anatomy is very important as well. And I want you to remember one variant here, which is very important variant. Why it's very important variant? Because it can actually it tells where it's type B or type A. If there is inferior right hepatic vein, like what we see here, draining the inferior right lobe, okay, you can tell that this is type 1A, this is type 1B. Type 1B is right inferior right hepatic vein. Type 2A here also what tells type 2A from type 2B is the presence of inferior right hepatic vein. Okay, and the same thing for type 3 and type 4. And all of these are very important. An example of how important is of this is that you see here, this is metastatic deposit involving segment 7. And I want you to focus with me here. Okay, so this is right hepatic vein, right? This is right hepatic vein. What is this? That's metastatic deposits. It's abutting the right hepatic vein, so the right hepatic vein has to be taken out as well, right? But if you follow this, I'm gonna stop at a certain point here. Do you see this? This is the origin or the drainage of right inferior hepatic vein into the IVC, right? Which actually drains the segment 6 of the liver, not segment 7. Okay, so you have metastatic deposit higher up superiorly, and it's abutting the right hepatic vein, and you have right inferior hepatic vein. What this will help the surgeon, when you mentioned how this will help the surgeon, it will help the surgeon in sparing segment 6. So surgeon would be happy to just take this out together with adjacent right hepatic vein and leave out segment 6, because segment 6 would be drained by the right inferior hepatic vein. And that's why you need to mention this in your report, right? Inferior hepatic vein and any variant. But those are examples of these variants. And here, this is the post resection. You can see here that this is a very localized resection of segment 7 metastasis. And you have spared here the segment 6 of the liver because you see the right inferior hepatic vein draining it. Okay. Moving to the biliary anatomy and the variants, which is also very important. So this is the classic anatomy. Same thing. This is the main common hepatic duct. This is left hepatic duct. This right and right is dividing into right posterior and right anterior. Several variants here, and again also account for about 34% of the cases. Mentioning some examples of them. For example, this is a case of what do we see here? We see right posterior duct draining into the left hepatic duct. Okay, that's MRCP. Right posterior duct going to the left hepatic duct. Okay, what happened if you don't depict this? And this was not depicted here, is more volume rendering, image of the same entity. Pyeloma, the same thing here we have this left large cholangiocarcinoma. They wanted to do left hepatectomy, so they will take this out. But they have not detected the anomaly that I showed you, which is the ribosere duct originating from the left duct. So what will happen? There will be leak. There will be bile leak because they will not ligate this duct on surgery. Okay? So this is the importance of depicting the anatomical variants and vascular variants before surgery. Moving on to types of surgical resection, you have the anatomic resection and the non-anatomic resection. The non-anatomic resection is what I showed you in the previous case, which is basically a wedge resection of metastatic deposit. Why the anatomic resection is preferred by many surgeons? Because you resect the coronal segment with selective ligation of the inflow portal triads and the dominant outflow hepatic vein. So it's safer because you resect an anatomy with its blood supply and drainage, right? So you resect areas distal to the tumor that are at high risk for vascular micrometastases, correct? Within the same segment. You have higher rate of negative margin, resection margin, 98% versus 84% for wedge resection. And you have less operative blood supply. Again, because it's anatomical resection and better survival. But the non-anatomic resection, the only advantage for this is preservation of liver function, particularly in cirrhotic liver, where you need a larger amount of this liver to sustain the function of the liver. So I'm gonna show you some schematic to tell you what are the types of surgical resection here that are most well known. This is right hepatectomy, anatomically taking out the entire right lobe. Right trisegmentectomy, or you even sometimes see it as extended right hepatectomy. So you basically take the right lobe out together with segment 4 of the liver. This is extended right hepatectomy, like this. What about left hepatectomy? You take out and resect the left hepatic lobe, as we can see here, and you just take it out. Again, all of these are anatomical resections, right? But you can also have left extended hepatectomy where you go and resect also segment 8 and segment 5 together with the left liver. So those are the main types, or you can just have, as I said, you can have just segmentectomy. Those are the main types of surgical resection. Let's try some case and see what, I consider surgeons really, and these cases which can survive is a great thing, because when you look at a case like that is of colon metastasis, you think that this case is a matter of time and the patient is in this stage and gonna die, right? Because you see large metastases is bilobar, right? As we can tell here, very important to detect them. As I said, detect the extent to depict every small one. So there is one here, even in segment uh, 3 of the liver, or 3 of the liver is extending to 1/3 of the liver, you know, and you have multiple right liver loop. So you have bilobar hepatic metastases. What are you gonna do with this? So what they do is usually start by chemotherapy after to downstage the tumor. So they have downstage here the tumor, and the metastases have become much smaller, as we can see compared to the previous video that I showed you. Even segment 2, this is 2 mainly, and extending to 3. Segment 2 here has also significantly decreased. So entire liver metastatic burden has decreased in size from before. And then they will proceed to right hepatectomy and wedge resection of the left liver uh, metastasis. So that's what are the advantages and disadvantages? So sort of pros and cons of chemotherapy. So the advantages is downsize the tumor. So you can downsize the metastases. It can treat micrometastases, has a better prognostic value, increase the prognosis, increase the survival for these patients. and conversion of unresectable to resectable disease, and has better prognosis-free survival. The disadvantages is what? Number one is basically complications. You can have hepatotoxicity and other complications, and of course it's miserable to take chemotherapy, and including hepatotoxicity, right? But two more important disadvantages regarding the surgical planning is number one, you can have progression with loss of surgical window. Some people may argue this is a biological tumor and the nature of the tumor, so we better, it was better that you didn't resect it because it would have recurred anyway. But one of the disadvantages, as I mentioned, progression with loss of the surgical window. And second one, when you even have complete radiologic response, you may not be able to see it, to see the metastases and where they were. What do you do with synchronous liver metastases? Like when you have rectal cancer together with liver metastases, what do you do? You treat and treat the liver met first. That's what they do in my institution. Okay. So metastases detected before or at the time of diagnosis of primary tumor are resected first. That's a definition of synchronous liver metastases. About one third of patients can have like metastases at the time of presentation. Other thing about metastases are synchronous ones are more common and more numerous and more often bilobar. It has worse prognosis, that's why, and they can be associated with more disseminated disease elsewhere. The expert consensus is you give chemotherapy before surgery, and you do the surgery first before the rectal or colorectal cancer. This is an example of metastatic deposit of colon cancer with synchronous liver metastasis, and it's treated by wedge resection like what we see here. What about disappearing metastasis? This is a very important topic because many surgeons believe that this will remain metastatic. That will actually this have the tumor. This has the metastasis, but you don't see it with the naked eye. You don't see it on imaging. Even it disappears. So you can always look at the previous one, the one that before the previous examination. Okay. Some surgeons try to treat this even though it has disappeared, like what we see here. So this is disappearing liver metastasis, for example. You see the met here has disappeared and has reappeared again. So the lesson is to take a look at the one that is even before the previous exam. That's first one lesson. Number two lesson is that uh, several of these metastases can have met even though you don't see it. So pathologically, they do have metastatic disease. So the disappearing liver metastasis in general, overall, it seems to be radiological, not biological, not pathological, because the rates of macroscopic and microscopic residual and local recurrence are high with this specific condition. And some observations still choose to observe over intervene due to the belief that these lesions may be readdressed in the future. So some tended to just take it out or treat it with ablation or with local regional therapy, and others, just keep an eye on it to, observe it, pay attention to these in the future. Another example here of synchronous liver metastasis, whereas the liver metastasis here is the most inferior in the liver. This one was hemangioma, but this is a case that has been large and you know, it has not morphologically changed after chemotherapy. So after chemotherapy, I want to show you the case that is before this event because it shows you two things here. You see how ill-defined, how heterogeneous it is, this metastasis here, right? If you follow on it, you will see it heterogeneous and ill-defined margin, right? And after chemotherapy, what happened here? This is, you can safely say that this is complete response, morphologic response, because in colon cancer, you have the morphologic criteria rather than the RECIST. RECIST 1.1 is like basically obtaining the maximum dimension, but morphologic response is you look at the margin, you see how crisp, how well circumscribed it is, and how the lesion is of low attenuation. This is very low attenuation and become homogeneous here. So that's morphologic response. This is what we talked about it here in this case. There is lack here of morphologic response. So this is what this one is not really it's partially actually. So see how heterogeneous it is. You see how lower attenuation became lower in attenuation, it become more circumscribed. So this has partially responded. So morphologic criteria, which is homogeneous attenuation and sharper margin, been published in our group in the MD Anderson and has been proven to be effective. Hepatotoxicity may not be identifiable on imaging, and that's a problem on imaging is that you can see the liver as normal as that, but on surgery you can see it nodular and diseased during operation. So hepatotoxicity injury may not be identifiable in
دكتور
preoperative.
خالد دكتور خالد ازي حضرتك؟ انا دكتور وسيم معاك. طبعا صباح الخير عليكم. انت في امريكا
أهلا
طبعا
وسهلا.
صباح الخير. بس احنا we are running out of time. قدام حضرتك قد ايه كده؟
حبيبي أنا الليكشر بتاعتي is 45 minutes. دكتور فوزي knows that about that. And I'm still having 50 minutes.
كان concise them في مثلا في حاجه.
No, I can't concise them, Dr. Wasim, with all of my due respect. The deal was 45 minutes. I'll try to, but I will try to conclude it. Thank you. And I'm sorry, but I want to be in Egypt. We want to be more, respectful. I mean, I ran from a big meeting and I leave it just for Masr, for Egypt, for you guys. So, and I said 45 minutes, so it's 45 minutes. Let me take the 45 minutes, please.
اوكي
Thank you. Thank you, Dr. Wasim. ازيك يا دكتور وسيم اولا so sorry about that but I just this is one of the things that I really want Masr to move forward with it which is really we have time respecting our time and the time management. So anyway, moving on.
In fact, the audience are
What
very
are the
happy.
criteria of surgical resectability? The
Okay,
criteria
go
of
ahead.
surgical resectability here is achievable resection margin, clear resection margin, preservation of two liver segments, preservation of biliary, arterial, portal, and venous flow to remnant liver, and 5% hypertrophy after portal venous embolization. And we need to look at the future liver remnant, which is 20% of the normal liver. So if you have the liver normal, then the patient can sustain with 20% of the normal liver. 30% after chemotherapy, 40% in cirrhotic liver. This is what you need to have after surgery. So after surgical resection, you need to preserve two liver segments. You need to achieve clear resection margin R0, and you need to preserve biliary, arterial, portal, and venous flow to the remnant liver. Okay, and we actually segmented the liver like this, and we obtained the volumetric assessment of the liver. This is a case of liver metastases. You may think that you can't ever resect this, but the plan here is again to give chemotherapy, obtain some response, and then resect, and resect even this. So what they do here is they did portal vein embolization of the right liver since they plan to maintain the left liver function to take over. So they do chemotherapy first. They do portal vein embolization aiming to atrophy the right liver and the hypertrophy the remaining left liver and resect this segment to metastasis here within the within segment 2. Okay, again the same thing here is multiple bilobar hepatic metastases, mainly within the right, but you see one within segment 4. So you have to do extended right hepatectomy. How can this small liver take over the liver function after surgery? Again, you do the chemotherapy, you do portal vein embolization to embolize the right portal vein. When you embolize it, you cause atrophy of the right liver and really hypertrophy of the residual liver volume. And this is after really measuring again the liver. Another example here is the same thing, and this is a post-surgical outcome. It's actually great because you see the remaining left liver hypertrophy taking over the liver function, and you even have resection here of the single metastasis within the liver loop. So you may think that every colon cancer mets can actually survive and can have a normal life, which is actually true. So you obtain, this is an example of future liver remnant, okay? You measure it, how you measure the liver volume. I mean, there are some softwares available. So you estimate the liver remnant, uh, which can take over the liver function. So estimation of, it's been reported in the literature that estimation of the future remnant liver function is a better tool to predict post-hepatectomy liver failure than clinical and laboratory scores. Okay. So assessment of the future liver remnant volume is very, very important. And we can see here how atrophic it is. How can this left liver sustain the liver function in the future? So again, we obtain the measurement for the whole liver and for the remaining left liver here. And we assess this together. And we obtain the future residual liver volume. Here it was only 18%. If you remember, I told you you need 20% of the normal liver to sustain and take over the liver function after surgery. And this is what we do, portal vein embolization, leading to embolization of the right portal vein and test the capacity of the liver to regenerate. And it can lead to, frequently lead to post-operative complication decrease, post-operative complication decrease, hospital stay, and 90 days mortality rate. An example of right portal venous embolization, right portal vein embolization here, and after measurement, after the portal vein embolization, you see how much of the left liver hypertrophy. It hypertrophy to 28%, which is good enough to sustain the liver function. Then they did the surgery of right hepatectomy, and you see how the residual liver volume has hypertrophied. This is 6 months after surgery, leading to better outcome. And in MD Anderson, we do it by automated segmental volumetry, and and you actually can automatically segment the liver and provide even a preoperative virtual, what's called automated virtual resection that imitate the exact surgery, and look at it and try to uh, segment it and show the surgeon which vessel is involved and which is not. And here is the tumor, and here is the surrounding liver. You have the vessels here, and the surgeon can preoperatively assess the surgical resectability by obtaining the segmentation here, segmentectomy. By AI models also, we can predict the you know post-operative recurrence by radiomic picture. This is still under research, by the way. These two slides under research. I'm not gonna talk further because Dr. Wasim طبعا حبيبي, فأنا sorry Dr. Wasim, but I have to just give the exact whole benefit for the audience. So the conclusion and take-home points. Number one is detection. You look at the indication, of course, surgical indication, everything, but after that, the detection. MRI is the best, especially with the gadoxetate disodium, known as Primovest. In MR also, you have other tools, which is like in phase, out of phase, in cases of fat infiltration, which is limited by other modalities. You have the EUVEST, as we said, hepatobiliary phase, You have MR elastography for assessment of fibrosis, and you can look at T2 and other pulse sequences. Proper characterization, and I mentioned to you some examples that were misinterpreted. Proper staging to confirm that this is liver-only disease. It doesn't make sense to resect something that has been already metastasized elsewhere. Then anatomically equalize it for the surgeon, mention the number, and as I said, UVest or PUMVest will improve the detection, vascular patency, as well as depiction of any variant. Anatomical variants are very important. I showed you examples which led to complications because of the radiologist not being able to detect them. The criteria of technical resectability is you need to have at least two liver segments with achievable clear resection margins and preservation of two segments with their blood supply and blood drainage more than 5% hypertrophy after portal vein embolization. You need to have the minimum future liver remnant. And thank you very much. And عشان خاطرك دكتور وسيم, I have taken 7 minutes of my lecture. And thank you very much everyone. My main intention دكتور وسيم really was ان انا يعني to give the whole benefit to my colleagues, and I did not exceed my time. I actually was limited within the 45 minutes. Thank you very much, everyone. Always happy to be with you, inshallah.